Welcome to the Prevent the Preventable podcast, where quite simply, we're on a mission to help you live longer by preventing health complications before they start. Every year, there are millions of cases of brain hemorrhage, but there really doesn't have to be. And at the Natalie Kate Moss Trust, we're committed to ensuring that those that don't have to happen don't. In this podcast, you will learn more about brain hemorrhages, their causes, how to prevent them, and so much more. Expect honest, straightforward conversations that will give you the information you need to take back control of your own health and potentially prevent the preventable. Hello and welcome to today's episode of the Prevent the Preventable podcast, where today we will be answering your most frequently asked questions about brain hemorrhages, such as what causes them? Can they be treated? Are they hereditary? And are there certain genders or races that are more likely to have a brain hemorrhage? Now, brain hemorrhages can feel like a bit of an enigma, and it's this uncertainty that surrounds them that can lead to a sense of hopelessness. But with the right information, hopefully we can start to change this so that we can better treat them and potentially prevent them too. In today's episode, we will be joined by Professor Adrian Parry Jones from the University of Manchester, who is a consultant neurologist and researcher, and whose research focuses on improving the outcome after somebody does experience an intracerebral hemorrhage. Adrian's work is around the ABC bundle, which we've heard about before, which is a treatment that has now been rolled out into the NHS and proving to save lives and showing that there is hope. If you have ever had questions around brain hemorrhage or ever felt this sense of uncertainty around the subject, then this episode is for you. And if you know somebody else who also could benefit from listening to this information, then please do send it to them. Now, without further ado, let's speak to Adrian. Adrian, welcome to the Prevent the Preventable podcast. Thank you very much for joining us. Obviously, today we're going to dive into some of the frequently asked questions around brain hemorrhages. But first of all, I kind of want to understand a bit more about you and your work and your work with brain hemorrhages. Can you give us a brief history of your work to date in this area?
Yeah, absolutely. So I guess it goes back to about sort of 10, 12 years ago. So I was a neurology trainee at the time, and I'd done a PhD in stroke using lab models to look at ischemic strokes, or the other type of stroke. And I was wanting to get back into research, into academia, and I started again as a clinical lecturer at the university. And that was really the first time I think I had a really big block of working with stroke patients. I was on call for stroke at the stroke unit at Salford Royal Hospital. And around that time was when we started to be able to deliver clot-busting treatments for ischemic stroke patients. So it was quite an exciting time. There's a big change in how we were looking after stroke. And what I would experience then was that we'd have these patients who would come in with suspected stroke. Everyone was, rushing around to get them into the scanner as quickly as possible, because the first thing you have to do to give the clot-busting drug is rule out a hemorrhage. Yeah. And with the clot-busting drug as well, you have to give it as quickly as possible. So the quicker you give it, the better it works. So there'd be this big sense of urgency. Everyone would be rushing them to the scanner. And then, obviously, in 1 in every 10 cases, we'd find there was a brain hemorrhage. And at that time, there was probably very little we could do, apart from just general supportive care. So I'd sort of immediately witnessed the sort of wind drop out of everybody's sails and everything would stop. And it just immediately thought, like, here's an area where we need to do a bit more research, where we need to try and improve care. So I had a real switch at that point. I thought, this is what I want to work on from now on. So I focused on it from there. I started to build up a bit of research. I think I had my first paper published around intracerebral hemorrhage around 2012 or something like that. And then I eventually got a really big chunk of funding from the National Institute for Health Research back in 2015, and got funding to start a big program of work looking around whether we could target inflammation as a treatment for intracerebral hemorrhage. And while I was getting that all set up and running, I kind of thought, well, whilst we're developing a new treatment, I'm sort of witnessing around me that we're probably not delivering the standard care we can deliver as well as we can. And that was kind of when we started off with the ABC bundle. And I think from there, I've sort of taken those two things forward and expanded it out into other areas more recently, which we can discuss further if you like.
Yeah, absolutely. So, and I want to talk about it, and you've already kind of touched on it. I think it's really interesting, this sense of this lack of hope and this helplessness. If somebody presents with a brain hemorrhage, you come in and everyone feels a bit like, oh, there's there's not a huge amount that can be done, which obviously there are certain things that we can do, which is to your point around this ABC bundle, which we'll come on to. But obviously, and I've got some stats here. Within 1 month, obviously 3 out of 5 people will survive a brain hemorrhage. Obviously, there's 2 out of 5 people there that won't survive. And then again, I think it's here within 2 out of 5 patients will then survive at 5 years. So obviously, even if you do survive that first month, there's still this sense that, you might not make it to 6 or a year or even 5 years again. So, the statistics around it are so devastating, and they've not changed in 40 years. You compare that to breast cancer I've got here has doubled in terms of the survival rates in that period of the last 10 years, with 4 out of 5 people surviving that rate.
Yeah.
We're hearing about brain hemorrhage. We hear about breast cancer. We hear about all these other conditions, but we don't hear as much around brain hemorrhage. And I think it's that lack of maybe discussion or interest or people talking about it that's maybe also encouraging that sense of hopelessness as well. So I think the more we can have these discussions as well, the more interest, the more research, the more we can move things forward.
Yeah.
And so I guess that word of hope is a big part of the work that you've done on the ABC bundle. Can you kind of, we talked about this with Katie a little bit on her episode a few weeks ago, but from the person who's developed it, can you explain a little bit more around what does the ABC bundle stand for? What does it do?
Yeah, absolutely. So, so obviously I've touched on the fact that I definitely sensed this kind of this hopelessness amongst the clinical team. And I think one key turning point was that there was a trial published in 2013, which is called the Interact 2 trial. And that was one of the first ever positive trials for intracerebral hemorrhage. So it showed that if you rapidly lower the blood pressure in people when they come into hospital in the first 6 hours, so if they're within 6 hours of their symptoms coming on, you can improve their odds of a better recovery. So it showed that there was a lower risk of death and disability as a result of that.
And just to ask a question at that point, is that because your blood pressure will, if you have a brain hemorrhage, it will automatically raise, you'll have high blood pressure as a result?
That's right. So it's a sort of natural response to the bleeding within the brain that the blood pressure goes up. And the theory is that the higher the blood pressure, the more likely you are to rebleed into the brain. Okay. So the hypothesis that underpinned the trial was that if we could bring it back down again quickly, you'd reduce the risk of further bleeding and people might have better outcomes as a result of that. So that trial got published in 2013 and it first made it into a set of guidelines around 2015, I think, which was the American guidelines. So it became a recommended treatment around then. So the other thing that we had been doing already, albeit with less evidence, is that we reduced blood thinning drugs in people who come in because obviously if you have that on board, your blood's thinned, you're more likely to bleed into the brain again. So we thought, well, what if we combine that drug, anticoagulant reversal and blood pressure lowering together? Unfortunately, they spelled A and B, so we had to think of a C. And the other thing that we do in ICH patients is consider whether neurosurgery is an option. So we knew that pretty much what happens in most cases, it's the first thing people think of when they see blood on a scan. They pick up the phone to the neurosurgeons, and great majority of the time it's not recommended that an operation is performed because we don't really have good evidence that it's helpful. But in about 1 in 20 people, the neurosurgeons will operate on them, usually as a life-saving procedure to reduce the mass of blood that's in the head. So,
by draining it, or what are they doing?
Yeah, so in the UK, the way it's usually done is by open surgery. So part of the skull is removed, and then the surgeon dissects down to the hemorrhage and will remove all the blood, control the bleeding, and then close up again. So it is done, as I say, mainly to reduce the mass of blood in the head, which increases pressure and causes shifts within the brain compartments. So what we wanted to do instead was to think about, well, can we focus that referral a bit better? Can we think about who actually needs to be referred to neurosurgery, who are they genuinely going to consider for an operation, and who will definitely not benefit, and there's no need to waste your time making a referral. And by doing that, we hoped that it would focus more attention on the A and the B, so that people wouldn't kind of pick up the phone to surgery straight away. So our C then became care pathway, which was about who do you refer to neurosurgery.
And how do you make that decision?
Well, it's a difficult one. So because there's no hard and fast evidence about who to refer, what we did was we came up with a consensus between all our neurosurgery team in the hospital. That got agreed by the neurosurgery department. We took it to the stroke team, who were agreed, and took it out to the wider region as well. But what we also did was there's a database of referrals for patients to neurosurgery for intracerebral hemorrhage, and we said, well, if we applied our criteria to all of those patients that have been referred in the last 3 or 4 years, let's look and see if people who we're not going to refer now actually went on and had an operation. And we found that it fitted very well. So basically it picked out all the patients who went on to have an operation, and all the ones that weren't picked out by our criteria didn't get operations even though they were referred. So we had that sort of check against it. So that's how we've managed it going forward.
Yeah. So going back to the A.
Yeah.
Well, no, the B. Sorry, the blood pressure.
Yeah.
If obviously, as you say, it's a natural result somebody's to blood pressure to raise when they've had a brain hemorrhage.
Yeah.
What if they already have high blood pressure? Can you lower it that rapidly in the same way?
You can. There's a variation in terms of how easy it is to lower people's blood pressure. So people who have high blood pressure before their stroke, it tends to be harder, and also people who have bigger bleeds have a sort of more a stronger response, if you like, to the hemorrhage and a bigger surge in their blood pressure. But the way we do it is to give intravenous drugs, which are quite powerful, and we rapidly escalate the dose against the blood pressure target. So we're trying to get it down to between 130 and 140 within an hour of starting treatment. So it's actually quite difficult to do. It sounds simple, but for the clinical team to sort of deliver that treatment was really challenging, which required quite a lot of work.
Yeah, and I think we've spoken about this before, and I think a major challenge is not that you're just going to one hospital and getting the team there to deliver it. You know, I mean, this has been rolled out into the NHS, and I think now it's being rolled out into the NHS England and sort of nationwide. Is that right?
Yeah.
And so what you're trying to do is roll this out, these guidelines, this way of kind of treating somebody when they comes in to tens of thousands of clinicians across the country, and to make sure that they do it in the same way, and it's kind of and they do it well as well. Must be a real challenge too.
Yeah. Well, I mean, so what we did so far was we did it in the 2015 to 16 at Salford. So that's relatively easy. So it's, the hospital I work in had a lot of sort of, we had a team working with me, and we sort of oversaw everything. And then our first attempt to move it into other hospitals was the 2 other hyperacute stroke units in Greater Manchester. So we learned a great deal by doing that, I think, because it's much more challenging to take it somewhere else and try and get it up and running. And I guess some of the key lessons that we've learned along the way, as we then scaled it up to the north of England, and as I say, we're hoping to scale it up nationally this coming year. Access to good data is a really important thing. Sounds boring, but I think you have to get it quickly. So, and you also, it has to be seen by the right people. So it has to be seen by the people delivering care. So when it works really well, what we found is that the people who are collecting the data are often the people who are delivering the care. So they're constantly looking and saying, what happened last time I did this? Could I be quicker next time? So they're very aware of the data and the timings, and that if you can do that, that works really well. Then I think you have to win people over with stories a little bit to win hearts and minds as well. So you could use data to persuade people that you should be doing this. But I think we've worked on that previously and had patient stories that we've recorded and that we've used to sort of share with the teams in local hospitals to try and win them over and get them into it. And then I think the other key things have been that when the teams are really well prepared and everyone understands what their role is in the project, that's worked really well. And also when teams are really proactively engaged with everybody else in the hospital, because this isn't just the stroke team that are doing this, it touches on hematology because they give us the reversal agents for the blood thinners. It touches on the emergency department, sometimes on radiology, critical care, and so on. So if the teams have really reached out to all of them and got them on board at the beginning, that's been really helpful. So it sounds simple, but it's to actually make this fly in a hospital, it takes a great deal of work from a lot of people and quite a challenging thing to do. Yeah,
I'm sure. But it's had huge progress. We're looking at improved survival rates quite significantly if somebody has a brain hemorrhage. What are those sort of statistics? What are those numbers?
So when we did it at Salford, what we did was we collected data for the 2 years before we started the project and for 2 years afterwards. And what we found was that there was a reduction by about a third of the proportion of people that were dying within 30 days of admission. So, I have to be honest, I didn't expect that it would be
that's
that
really
successful,
significant.
actually, and we were obviously delighted that it was. When we scaled it up across Greater Manchester, the numbers weren't big enough to make any clear assessment of what effect it had on survival, and we're doing an assessment now of the North of England scale up. But that initial work has certainly been very encouraging.
Yeah, that's significant, and I think that we go back to that word hope that we talked about earlier, in that sense of like the lacking of hope after somebody does have a brain hemorrhage. It's really exciting to kind of see that there is something there that we know that if somebody has a brain hemorrhage, it's still very devastating in many different ways, but at least there's treatments that are coming through that potentially increase the chance of somebody surviving. So I think for anyone listening, I think that does offer a sense of hope. But there's many different questions, as we spoke about before, that they will have around brain hemorrhages. So if we break it down, what are the two main different types of brain hemorrhages?
So what I've been talking about so far is intracerebral hemorrhage. So that is bleeding into the brain itself. And then the other type is subarachnoid hemorrhage, which is bleeding into the subarachnoid space, which is a fluid-filled space that sits around the brain. So those are the two types.
But the bleeding will still come from the brain, but go into that space. Is that right?
So yeah, if you have a subarachnoid hemorrhage, it's most commonly from an aneurysm, and those aneurysms form on the arteries around the base of the brain. So those arteries sit within the subarachnoid space. So if the aneurysm ruptures, it usually goes straight into that subarachnoid space. If the bleed is pointing in a certain direction, so towards the brain substance, you can get both. So you get bleeding into the brain and into the fluid around the brain. But yeah, that's it's a bit of the way it presents itself clinically, and who looks after it is different. So people with subarachnoid hemorrhage tend to have what we call a thunderclap headache. So it comes on very suddenly. They get a very severe, worst headache of their life. If it's very big, people sometimes collapse, lose consciousness, things like that. And it can cause vomiting, photophobia, so a sort of aversion to light and so on. Whereas intracerebral hemorrhage presents like a stroke. So we can't tell it from a ischemic stroke until you do a brain scan. So the two are actually quite different in terms of how they look clinically when someone comes into A&E. And also, subarachnoid hemorrhage in the UK and in most countries is looked after by neurosurgery, whereas intracerebral hemorrhage is predominantly looked after by the stroke team.
Okay, that's interesting. So can you apply the ABC bundle to either one of those, or is it just for
No, it's just for intracerebral hemorrhage, yeah.
Okay, and what would be the treatment, for if somebody has a subarachnoid hemorrhage? Is it just surgery, or...?
So with the subarachnoid hemorrhage, they first thing they would try and do, the neurosurgeons, is predominantly diagnosis is easy because you see the blood on the scan, but very occasionally it's not, and it requires a lumbar puncture to detect blood products in the spinal fluid. So they make the diagnosis. Usually a scan is done of the arteries around the brain to look for an aneurysm, and it's usually found in most cases, but you get odd cases where there's no aneurysm, which is called a non-aneurysmal subarachnoid hemorrhage. And if they do find an aneurysm, then the next step is to try and treat it to control the risk of any further bleeding. In most cases, they have a ball of coils put inside it, which makes it clot off and prevent further bleeding risks. And occasionally surgery is done to go in and actually put a clip across the neck of the aneurysm to treat it. And then they just have good supportive care is important for them as well to reduce the risk of any complications happening afterwards as well. But that's the crux of care. So it's very centred around neurosurgery and these interventions that they offer to control the risk of further bleeding. Yeah.
So an aneurysm that we're discussing is a bulge in the blood vessel that would burst in that situation. So how would somebody... why would someone have an aneurysm? How do they develop it? Is it from birth? Is it that it develops and grows? Is it because of an injury? Like, why would they have it?
So they usually develop and grow later in life. They share a lot of the same risk factors as intracerebral hemorrhage. So smoking, high blood pressure. There's a hereditary component to it. So they can sometimes run in families. And they tend to present between people. People are often at the age of around 50 or 60 when they have a subarachnoid hemorrhage. That's more common, whereas intracerebral hemorrhage tends to be older than that on average, although it can affect all ages. So yeah, the risk factors are similar. And it causes this sort of outpouching of the vessel wall, which is the aneurysm, and that can ultimately rupture.
So are you saying then that lifestyle is the biggest contributing factor then, opposed to, as you did mention about potentially being hereditary? Is it more that, if we can manage our lifestyle, we could reduce, or as a population, we could significantly reduce the number of brain hemorrhages versus it being something that just happens?
No, that's absolutely true for both types of intracerebral hemorrhage and subarachnoid hemorrhage. So, there's obviously things you can't modify, there's age and so on, but the things that you can modify that are commonly associated with the risk of hemorrhage are Smoking, I mentioned. High blood pressure is by far and away the biggest. So if you look at, we've just published a fact sheet for the World Stroke Organization. I looked at all of the global data around risk factors for intracerebral hemorrhage now, and across all countries and all socio-demographic indexes, hypertension is just the biggest cause across the board. Having a lot of salt in your diet increases your risk, probably because it increases your risk of high blood pressure as well. Alcohol, so high alcohol intake will increase the risk, being overweight, and also having an unhealthy diet as well. So all of those kind of modifiable lifestyle things are really important and increase your risk if you don't look after them.
Yeah, and I suppose when we did a panel discussion for our corporate partners a few months ago, when we had Adam Greenstein on the podcast as well, he kind of said, blood pressure is a red flag to your health, and it kind of is a signifier to all of those different things that you've spoken about in terms of like, well, actually, if your blood pressure's high, maybe you should be looking at your diet, how much exercise you do, your weight you're carrying, etc. Why do you think we don't manage our blood pressure better as a collective, as the nation?
Yeah, it's an interesting question. I have to admit, I only started checking mine probably in the last year or two. And that's knowing my mum has high blood pressure as well. And I think, I guess the most obvious thing is it doesn't cause you any symptoms, so you don't know you have it. And I think when people are bobbing along and they're quite healthy, they don't want to suddenly be told I have a problem that I need to take medication for. So they'll tend to perhaps avoid it and not have it checked. So a common thing is when I see people in clinic who've had a brain hemorrhages, and I'll ask them if they have high blood pressure, and they just say no. And then if you ask them if they've ever had it checked, they'll kind of think back and go, well, actually, no. Yeah. And so I think, you've got to get it checked to know. And
I think there's a piece around the lack of awareness of the severity of having high blood pressure as well. Because when we obviously talk about this a lot. And when we do awareness days and, we have people sort of, we'll do a stand and we'll have people coming up and we're talking to them one-on-one. And when we say to somebody walking by, do you want to have your blood pressure checked? And they go, I know it's high, and kind of like, almost like laugh it off a little bit. And, you obviously don't know the ins and outs of that person's life and they're walking off, but you kind of think, well, if you do know it's high, maybe it's important to sit down and just check it and have these conversations and understand what you can do about it. And so a part of me thinks, is it therefore about better understanding, as I say before, the severity of hypertension?
Yeah, that would probably help. If you compare it to, say, smoking, for example, there's been very visible campaigns around what effect smoking has on you, perhaps less so around blood pressure.
Yeah.
You get the letter from your GP to come in for a health check when you hit a certain age, don't you? And I think I ignored the first one I got, but I went in and had one recently. So, the primary care do very well at trying to get people in for them, and I'm sure quite a few people don't turn up when they get invited.
Yeah, I'm sure they do. So we've spoken about aneurysms. Are there any other things that we could talk about in terms of like potential causes or damages to the brain that potentially would lead to a brain hemorrhage, such as AVMs or anything like that?
Yeah, well, if we think about what causes intracerebral hemorrhage, the great majority are due to what we sort of lump together as small vessel disease. So there's two main types. One is the type you get from high blood pressure, and the other is something called cerebral amyloid angiopathy.
Which I won't try and repeat.
Long and scary name. But so the both of those two things, I think, count for the great majority. I think probably high blood pressure is the bigger cause, and cerebral amyloid angiopathy is something people get as they get older, so we don't see it really before the age of 50, and then it gets more and more common into people's 70s and 80s. So that takes up the bulk of it, and that's sort of older people usually. So if you have high blood pressure, it takes many years for the changes to start to happen in the blood vessels in the brain, which will lead to the bleed. So, what your blood pressure is when you're younger is sort of setting your risk later in life. So that's why it's so important to deal with it early. So that's the bulk of it. And then in younger people, when you wouldn't expect to find those two causes, we often look a bit harder for other causes. So the things that we do focus on are AVMs, you mentioned, something called cavernomas, which are another type of vascular malformation. And you can also get other things like, I mentioned before, aneurysms can bleed into the brain, and you can also get other types of abnormal communications between arteries and blood vessels. So we lump those all together as macrovascular causes, and there's a set of criteria for who we try and investigate for them, which tends to be around your age, and also whether you have other conventional risk factors for small vessel disease. So yeah, those get looked for because there are specific treatments for them. So if you find an AVM, then you can be offered treatment to get rid of it, which will reduce your or eliminate your risk of hemorrhage in the future if you have that treated.
And that would be treated how? Via surgery, via medication? How would that be? How would an AVM be treated?
So it depends very much on where it is and the anatomy of it, and other factors to do with your general health. So there's three main ways of treating an AVM. The first is that the surgeon can directly remove it, so you can have open neurosurgery to remove it. In some cases, it's possible to block the feeding vessel off by the neuroradiologist, so they're able to put something in, like a type of glue, if you like, to block off the feeding vessel, and that can clear it away if the anatomy fits with that. And then the third thing that can be done is what's called stereotactic radiosurgery. So it's a bit like radiotherapy, but essentially it causes the AVM to gradually to shrivel up and disappear. But that takes time. It takes a year or two for that process to play out after you've had the treatment.
So that would be after somebody. So somebody comes in presenting with a brain hemorrhage, and you would know what they have, whether it's an aneurysm, AVM, or whatnot, through an MRI scanner, or how would you know at that point?
Okay. Well, the first test we do is the first screening test is what's called a CT angiogram. So it's a type of CT scan where you inject a dye, gives us nice pictures of the blood vessels. And research has shown us that about 3/4 of macrovascular causes get picked up by that. Then if you still suspect one and you want to investigate further, you might do an MRI scan, which is the best way to pick up cavernomas. You can't see cavernomas on angiograms, so you have to have an MRI scan to find them. And then the final test that's sometimes considered is called a catheter angiogram, or a DSA sometimes. And that's where the radiologist puts a needle into usually an artery in your groin, your femoral artery, and they'll thread a very fine catheter up to the vessels to the brain and inject a dye in it. And then from the x-rays, you can see the dye moving through the arteries, and it gives us very clear sort of dynamic pictures of what's going on in the blood vessels. And that's the gold standard way of picking up a macrovascular cause or an AVM. So there'll be about 1/4 of people who need that to find it, and you won't have seen it on the CT angiogram. So that's the usual process of how you go and try and find one after somebody's had an intracerebral hemorrhage.
Okay, and then you would obviously take the right path for the treatment.
Yeah.
Can you check for that before a bleed happens? Can you be proactive and actually see, does somebody have an aneurysm, and therefore they could have a coil before it bleeds, or an AVM, and we'd clip it, or whatever they would decide to do?
Yeah, so that's, I suppose that's a difficult one, because what happens anyway now is that people have scans for other reasons. And it's said when you have an MRI scan, the odds of finding something incidental that you wouldn't have known about otherwise is about 1 in 30. So we quite often pick things like that up. And then you're left with a conundrum of what to do about it. So is doing something about it riskier than leaving it alone? And it's unfortunately a bit of a cause of anxiety for people. So the evidence around whether you should leave AVMs alone or not is a bit variable. So there was a trial done looking at whether if you leave them alone versus the various surgical interventions, and it seemed to be that leaving them alone was better because the treatments carry risks.
Yeah.
But every case is usually taken on its own merits and discussed with people, and sometimes it's decided that you go ahead and treat them anyway. I don't think we have any good evidence that we should be screening for them regularly, and I think because of that, because it's not clear that the treatment risks would outweigh the benefits. So I think you'd have to have that proven first. Occasionally, if somebody's got a strong family history of having had aneurysms and subarachnoid hemorrhages, then they do get screened.
Yeah.
And if aneurysms are fine, they might be coiled or clipped.
Yeah, I'm recording an episode tomorrow, which will be the last one in this first series of the podcast, which is with a charity called HBA, which is Hereditary Brain Aneurysms. Oh, right, okay. And their work is all around campaigning for better screening for if there is a high incidence of aneurysms in a family.
Yeah.
But I think it's one of those things, again, and I work in this space, obviously, a lot, and I don't hear about it as much, how common it is for somebody to go and have, checked whether they do have an aneurysm or whether it can be treated. And I'm intrigued about how, if that's developing, is there being work done in that area, research done to kind of improve the treatment so that, to your point, it's not a case of we're weighing up the risk of actually treating it versus leaving it alone, but actually treating it is always going to be, the better option? Is there any research that you know of in that space? A huge thank you to Hugh James Solicitors for sponsoring this first series of the Prevent the Preventable podcast. Now, having your life torn apart by a brain hemorrhage is one thing, but learning that it could have been prevented and it was due to a mistake in your medical treatment is truly devastating. And whilst nothing can change what has happened, Hugh James's clinical negligence team can support those who have suffered a brain injury or bereavement due to a mistake in their treatment. To find out more about how and if they can support you, head to our show notes now.
To be fair, it's not particularly aneurysms. It's an area I work in directly.
Yeah.
But I come across it fairly often clinically. So you get the odd referral of somebody who has a family history of someone with hemorrhage and they'd like a scan done. So I would often do that. If they're found, then there's the question of what are we going to do about it. And we have at Salford and in most hospitals, we have a neurovascular multidisciplinary team, which is a group of radiologists and neurosurgeons. So that case would usually be referred to them, and then they'd discuss whether treatment should or shouldn't be offered, and then speak to the person involved to sort of reach a decision together.
Yes, it's very, very much case by case.
Yeah.
So we would always get asked this question, in many different forms, and quite often it's when somebody's lost somebody, to a brain hemorrhage, and then they reach out to us, and they'll ask, are brain hemorrhages hereditary? Now, you've mentioned at certain points there's some aspects of certain things, whether it's aneurysms or whatnot. But if somebody came to you, or they just lost somebody to a brain hemorrhage, and they said, well, how am I at risk as well? Maybe they're a sibling or a daughter, or or whatever. What would your response be to them?
So in the great majority, if we think about intracerebral hemorrhage alone first to begin with, I think in the great majority of cases, then probably not. It's not going to be hereditary. But there are exceptions to that. So one hereditary cause is cavernomas. So about 20% of people with a cavernoma, it's hereditary, which is quite high compared to most other causes of hemorrhage. And there's 3 particular genes people can carry which convey that risk, and they've got a 50% chance of passing that on to any children that they have. So that's how it runs through families.
You test for that gene? You
can, yeah. So we can do that test. The people who carry one of those 3 genes will usually have multiple cavernomas. That's often a clue that they've got them. And then they may well have a family history. Thing is, cavernomas don't always cause any problems, so you might have one all your life and never know about it. But if they do cause trouble, they can bleed, they can cause epilepsy, and sometimes if they're big enough, they might press on parts of the brain and cause some neurological symptoms from that. So that's one particular cause where we do often think about it and test people genetically. With AVMs, most of them are not hereditary, they're congenital, which means that they're usually there when you're born or shortly afterwards. There are a few rare syndromes where people can have hereditary AVMs. So there's hereditary hemorrhagic telangiectasia, which people can have multiple AVMs throughout the body, sometimes in the brain, and they often have these things called telangiectasias, which are little sort of abnormal blood vessels that you see around their mouth and so on. So there's some clinical clues that people might have that. So that's AVMs, but and then with cerebral amyloid angiopathy, there are very rare cases where they're hereditary as well, and that's something that I've seen myself a few times in the clinic as well.
Yeah. Okay. Yeah, I think it's important for people to kind of a big part of this is understanding the facts. We said it early on, and I think and I will speak from experience with this. When somebody close to you has had a brain hemorrhage, it does feel like you're kind of walking a little bit in the dark, and you don't really know. I heard these terms of aneurysms and AVMs and whatnot, and I kind of was a bit lost of what does all this mean, and am I at risk? And so I think this is where this episode particularly is really important to kind of unpick a lot of that. But that is a huge question, I think, not only that people ask, but they will worry about, and they will consistently worry about.
Yeah.
One of the guys who did an episode, Miles, spoke about losing his mum, and he said for quite a while after he was worried about having a headache, and he was worried, am I now at risk? And so there's huge health anxiety that then will come for a lot of people as well. So I think it's important to lay that out, even in terms of the statistics that you mentioned, that 20% of cavernomas, but everything else as well. So is then or are there certain, whether it's a gender or certain races, are there people that are more at risk then of having a brain hemorrhage?
Well, if I come back to this World Stroke Organisation fact sheet that we did, because the numbers from that are fairly fresh in my head, we looked at the percentage split between men and women in in terms of kind of the incidence. So that's all the new cases, the prevalence, and the mortality. And there's a little bit of a lean towards men. So men are a bit more likely to have it, a bit more likely to die from it overall because it's a bit more common. And
is that to do with lifestyle?
I think it probably is, yes. So I think there's fairly good evidence that men are a bit less likely to sort of seek out medical attention, to have their blood pressure treated, to have, and as you say, there may be lifestyle factors associated with it as well. So that's what we see for intracerebral hemorrhage. The other really striking thing about the data is that there's a huge concentration of intracerebral hemorrhage in Southeast Asia, sort of Far East, Oceania, that kind of area.
Yeah.
So I think when we looked at the data, it was at least half of the burden of intracerebral hemorrhage, so that's the death and disability that it causes, is concentrated in that region. And that's thought to be potentially genetic, but also related to lifestyle. So there's lots of high blood pressure, there's a lot of salt in the diet and so on, and that's perhaps why it's so common there. So that's a real hotspot in terms of intracerebral hemorrhage. And the other big factor which came out was that if you look at the country's socio-demographic index, which is just essentially a measure of their sort of, it's made up of personal income, fertility rate, and a few other things. And if you look at that, 95% of the burden of intracerebral hemorrhage is outside the highest level of that. So it's very much it's very much a disease of people with of countries with lower socio-demographic index.
So you're not seeing anything in terms of genetic makeup according to race or whatnot. You're seeing it more associated with social factors or demographic factors.
I would think the social factors are a much higher part of it, but I think there's very likely to be some genetic component to it too.
Yeah. Okay. Yeah. Interesting. So in terms of preventing brain hemorrhages, is it more a case of yes, maybe if somebody does have a really strong history of having, brain hemorrhages in their family, potentially there's an opportunity for them to seek medical help and say, is there something I can do here? But the long and short of it for the majority of people, it's around just lifestyle and managing lifestyle, and therefore, and also managing blood pressure as a result.
Yeah, I think that's very true, and I think that's what you can alter, isn't it?
Yeah.
I think we spoke about aneurysms and screening for those if you've had a family history, and I think that's quite a different situation to intracerebral hemorrhage, and that's probably something people would want to explore. But yeah, I think lifestyle is the predominant thing that's modifiable.
Yeah, and that's what it's modifiable, but it's also, we've used this term before, it's a low-hanging fruit. It's very much something we can control. There are drugs out there to control it, but we can also probably control it, most people, through lifestyle as well. And this is where I think this educational piece is really important too. In terms of your work then, in terms of moving forward, what else do you feel needs to be done in terms of changing the landscape of brain hemorrhages from a treatment point of view?
Well, from my own research, I guess there's 4 key things that I'm working on now. We spoke about the ABC bundle, so we are hoping that we will be able to scale that up nationally this coming year. So I think that's obviously really exciting, and I think it's a great opportunity to start to understand how we can better deliver the bundle. So some nuances around how should we lower blood pressure, which drug should we use, and things like that. So that's hopefully going to be a great opportunity to move just standard care forward and make that better.
How long do those, in terms of improving that, in terms of testing things, you say testing around blood pressure, which medication is best to use. How long would you test that for and trial it for before it just becomes completely normal? Are we talking a couple of years? We're talking 10 years, in terms of the rollout of that treatment completely?
Well, I mean, I think in terms of proving a treatment works, you obviously need to run an adequately powered clinical trial, which means you have to have enough patients in it to detect the difference you're interested in. So that can often take 4 or 5 years to run a trial and finish it and publish it. It's very well recognised there's a huge gap between that trial getting published and treatments actually getting into practice, though. So that gap can take a long time to bridge. So if I go back to when we first did the ABC bundle at Salford, it had been 2 years since the trial was published that led to the change in blood pressure management. And that hadn't changed practice at our centre. It wasn't in guidelines, and so once it got into a guideline, we started to then do it, and then it was already 4 or 5 years then before we really had it properly running. So, that gap between evidence and implementation is huge and often takes a long time to bridge.
A huge thank you to Colony Co-working for supporting us with this first series of the Prevent the Preventable podcast and for providing us with this beautiful studio too. Now, at the Natalie Kate Moss Trust, we are a small team working remotely, but on a mission to make a big difference. But finding the balance between flexible working and working in inspiring spaces surrounded by inspiring people can be a hard balance to strike sometimes. Colony is an expanding network of co-working spaces in Manchester, a place for entrepreneurs, creatives, freelancers, startups, and established businesses. A place where everyone comes together, where ideas pollinate and businesses flourish. And Colony is helping NKMT do just that by supporting us with this podcast, by helping us reach more people with this vital message, and ultimately helping us to prevent the preventable. To find out more about how Colony can help your business grow, head to the show notes now.
Yeah.
And so what were the other pieces? You mentioned that was one of four things.
So the second thing is we're looking at developing new treatments for intracerebral hemorrhage. So I mentioned early on that we had funding to look at inflammation as a target. So that eventually led to me doing a small trial of a drug called anakinra, which is actually a licensed drug for rheumatoid arthritis. So we had the trial up and running when the pandemic hit, unfortunately. So we were aiming to get 80 patients in the trial, and we only got around 25. But we were able to show that we could do it and that it started to show some reduction in some inflammatory markers that we measured. So I'm keen to try and get some more funding to get that back off the ground again. And that's something that Stuart and the team have been working on in the lab as well, looking at different ways of targeting inflammation. So, the collaboration with them has been great with that, and we hope to move that forward. The third thing I think is shifting treatment into the ambulance. So, as I said early on, you can't tell somebody with a suspected stroke has a hemorrhage until you do a CT brain scan. But there's been a lot of interest around using different technologies to diagnose hemorrhage. So we're about to start a study this year looking at whether a combination of some clinical features, which are a little bit more prominent in patients with intracerebral hemorrhage, combined with a blood biomarker, might be enough to say that this patient's very likely to have an intracerebral hemorrhage. So if we could then do that simply in the ambulance, we could start to deliver some of the ABC bundle, basically. So
quicker.
You could potentially start to lower blood pressure. You could give things to reduce the risk of further bleeding and so on. So that's an area of research I'm really interested in. I hope will grow in the future and that we can start to really get in there when the risk is much higher. So in that first hour or so after the bleed begins, that's when you're really at high risk of further bleeding. And if you could get in then, that would be amazing. But first we've got to know the hemorrhages. So we're working on that.
Yeah, because I hear from you guys a lot, time equals brain, and that just sticks with me.
Yeah.
The sooner you can get in and understand first of all, and then make the right or take the right steps in terms of treatment, the better.
Yeah, that applies to both types of stroke. And I think in intracerebral hemorrhage, it's really about stopping more bleeding, controlling the bleeding. So we're certainly very interested in that and excited to do this study this year. And then the final thing we've been working on is sort of comes back to the thing you said about hopelessness early on. So we want to try and make it easier for clinicians to give a really accurate prognosis for somebody. And we try to do that, and I think we're reasonably good at it. But I think sometimes we don't take all of the information in that we could. So one thing we've been focusing on is looking at the brain scan and wondering whether we can use artificial intelligence to pick out certain features which might be quite predictive of a poor outcome or a good outcome. So we started doing some really interesting work around that and starting to get some interesting results. So we're hoping to move forward with that again this year with some further funding.
I'm sure that AI is going to become more and more prominent I've seen it in hospitals where it's become more prominent in certain areas, but equally in research, and surely, hopefully, as long as it's accurate, but you would assume it would be, that will only support the development of the research and therefore this treatment as well, you would hope. So
Yeah, absolutely. And I think, obviously one of the concerns about AI is a bit of a black box and people don't necessarily trust the output of it. So the approach we've tried to take is to get it to do something quite specific for us. So we've taken a set of data where we had patients who had scans, MRI scans, which show us the tracts within the brain, and a CT scan. And there's a particular tract which controls all your muscles down one side of the body called the corticospinal tract. And what we can see that on the MRI scan, but an MRI scan is really hard to do in somebody who's unwell with an intracerebral hemorrhage because you have to sit still for half an hour and it's not easy. So we've taught the machine learning algorithm to recognize on the CT where the tract is likely to be, because it's got the MRI scan and the CT scan. So we've taught it on this set of data and then presented it with some CT scans where there's no MRI scan, and it's actually predicting really well where the tract is likely to be. And we've shown from those predictions that we can predict who's going to recover in terms of their strength and who isn't. So I think in that way it's quite understandable. If you say we predict that this tract is damaged, therefore this is the likely prognosis, and we try and test that prospectively, then it's a bit more understandable, I think, than
Is there a risk with that the computer says this person is likely not to recover, and then they're like, oh, we've lost hope in you a little bit, and they don't get treatment that might in actual fact help them recover?
I mean, that's always the worry with prognosticating. And that's been a worry in intracerebral hemorrhage for a long time. So there's been quite simple tools that people have developed to predict how someone's going to do. And it's been long recognised that they then become self-fulfilling prophecy. So, you're going to do badly, therefore we withdraw care, and then you do badly. And so there's a lot of wariness of that. So I think if we were going to look at something like this, what we would do is develop it, but then test it in the background. So we'd want to very carefully validate its accuracy and make sure that it isn't making inaccurate predictions before you tested it out in clinical care. And I think that'd be the way you'd have to approach it.
And I'm sure it'd be something that we wouldn't rush into it, know, and just make it, put it straight into hospitals or whatnot. I think what's exciting about all those different pieces is that it shows that there's a lot of work being done, and there's a lot of work that can be done as well. It's not just being left. When we spoke to Katie on that episode a few episodes ago, she kind of regaled the story of when you and Stuart and her were kind of in the labs in the early days and trying to figure stuff out. And it's very those days are long gone, and there's a lot of work being done now, which I think repeating this word hope, it demonstrates that there is hope and that more can be done. And I think that's really, really exciting for a lot of people, whether they've experienced a brain hemorrhage personally or a loved one has, or, they're worried about potentially something happening in the future too. So thank you so much. We closed the podcast with a few questions. Obviously, prevent the preventable is alluding to the point that we spoke about before, which is the importance of lifestyle, the importance of being aware of how your lifestyle contributes to potentially something happening. And that could be a brain hemorrhage, but also, countless other health complications as well. So thinking of that, what is non-negotiable for you in your routine, your habits, or your life that is supporting your health?
Well, I guess for me, it's probably exercising regularly. So I guess probably up to about 2018. So I'd done quite a lot of exercise when I was younger. I used to play rugby and used to go running quite a lot, and then life gets busy, doesn't it? So had kids, was very busy at work, and sort of let that slide quite badly, and probably gained a bit of weight. And around about 2018, I think it was actually because somebody invited me to come and do the Great North Run. That's how it started, actually. So I thought, that'd be good, I'll get going again. And I think that was really transformational for me. And then I've gradually got into doing triathlons, which I don't think you necessarily have to do. But so now I sort of probably exercise most days, and I really recognise what a great effect it has on my health. So I think it's really good for your mental health. I think perhaps more than anything, I noticed that as a key thing. It's brought my weight down quite a lot, and it's probably brought my blood pressure down, although I haven't been checking it. But that's probably the one thing that I certainly wouldn't let slip now. So I find that has a huge effect on me.
I think it's like the knock-on effect that some of these habits have, isn't it? You do your exercise, you're probably then not going to, go and, I don't know, straight away drink loads or sit around or eat. You kind of think, well, what's the point cancelling it out? I've done that exercise, but it also makes you feel good. So you want to go and do more things that make you feel good as well. There's this lovely cycle to it too. If you could get more people to understand one thing, what would it be?
Well, I mean, we talked a lot about blood pressure, but so I'll perhaps not repeat that. But I think one thing that has changed enormously, but I think we've got a lot more work to do, is the recognition of stroke as an emergency. I think that's probably the one thing I'd single out. There's been fantastic campaigns run by the Department of Health to get everybody knowing about the FAST test, and I find a lot of people do know that now. But particularly around the northwest, we have quite slow times from symptom onset to the 999 call happening, and that's as a clinician, that's really frustrating because all the treatments that we give are so time limited. So, for hemorrhage, we only know that blood pressure lowering definitely works within 6 hours. The clot busting drug we usually have to give within 4.5 hours, and so on. So if there's one thing that I suppose I would wish for is that whenever somebody sees somebody with a facial droop, with a weak arm, or with some disturbance in their speech, that they immediately call 999, and we can get them in and treat them.
So just going into that a little bit, because when I've spoken to a few people where they've spoken about themselves having a brain bleed, and they've said, and I'm thinking of one lady in particular, and she thinks she had a brain bleed almost the day before she went into hospital.
Okay.
And I'm imagining that's not an isolated case, and there's probably quite a number of cases for that. So, particularly with a brain hemorrhage, it feels like this headachy, this sense of just something not feeling right. So rather than it looking at somebody else and going, I can see their face has dropped, there's weakness, etc., individuals themselves also wanting to kind of make sure that they take the quick action. Because I think to your point before, particularly around men, they're very much like, I don't need to seek medical help. I don't, and almost like not letting, whether it's your ego or whatever, just be like, I'm fine. That sense of encouraging people to kind of take proactive action
That's
themselves
a very
too.
important point, I think, we see that a lot. People come in and they'll say, I couldn't move my arm, but I thought it might get better, and I'd sleep on it, and that kind of story.
Or I had a headache and I'd sleep on it,
I guess you don't want to worry that there's something serious going on and bury your head in the sand a bit. I think it's a real sort of golden hour to sort of get help and get in and get treated.
I suppose it's and you must see this all the time, it's a really tricky balance between people not being too reactive all the time, any single symptom that they have to go, right, I need to go straight to the doctor. And then there's the extreme of they just ignore it and hope it gets better, but it's actually something quite, catastrophic.
Yeah, and I think that, the FAST test is what's recommended to sort of think about. And it doesn't pick up everything. So we know that about 10 to 20% of strokes aren't positive on the FAST test. You might have a visual disturbance or a balance problem or something like that, and you wouldn't be FAST test positive. It's not perfect. But on the other hand, some of the other, if there's other tools you tried to use which sort of captured everybody, we'd be overwhelmed by people coming in with suspected strokes. As it is, about half of what we see turns out not to be a stroke, and that's fine. And we'd rather people came in and got checked out, to be honest.
Yeah, great. Do you have a motto for life, and if so, what is it?
No, I don't suppose I have a motto. I suppose if I was to focus on one thing, maybe that I've tried to do over the last maybe 5 or 6 years is to focus more on things that are meaningful to me, I suppose. So I suppose if I go back 6, 7 years, I was kind of accumulating more and more work and lots of things going on that was getting a bit too much. And so I think what I've learned to do more in the last sort of few years particularly is to think about, am I going to do something because it really matters to me and it's meaningful, it sort of speaks to me? And if it doesn't, I tend to sort of try and avoid it so that I can focus on the things that really do matter. And like from a work perspective, that's predominantly, I sort of see my goal as trying to improve the lives of people sort of affected by intracerebral hemorrhage, however that might be. And so anything around that tends to sort of energize me, I guess. It's like following energetic breadcrumbs or something. You're on the right track when that's happening, and try not to pick up things which just don't really have much meaning for me. So I think that's probably been a key thing for me over the last few years. I've had to pick something.
Yeah, I think that's really great advice, because I think we can all get lost in everything. And I think coming back to the point of the podcast, we can actually veer away from what is important. And to be honest, what is important is probably the very foundation of it is our health, because without that we have nothing. So Adrian, thank you very much for joining us today.
It's a pleasure. Thank you.
Wow, well, there was so much helpful information in there, and I hope that you're leaving with more clarity and understanding about brain hemorrhages. And to find out more about Adrian's work and the research being done at the Geoffrey Jefferson Brain Research Centre at the University of Manchester, head to the link in our show notes. Now, as Adrian discussed, whilst there are many different causes of brain hemorrhage, one of the leading risk factors is hypertension. So if you do one thing after listening to today's episode, please make sure to check your blood pressure and to encourage your family and friends to do the same. And if it is high, simply go and speak to your GP. You can find out more about checking and managing your blood pressure in one of our earlier episodes with Dr. Adam Greenstein. And if you enjoyed today's episode, like I said right at the beginning, please do share it with other people who you know it would help. Now, we'll be back next week for our final episode of Series 1 on the Preventable podcast. But in the meantime, have a great week.